Welcome to the Buzz on Bioidenticals program, Achieving Hot Flash Relief for Women with Chronic Conditions. In this section, we will provide information on stroke. Many women mistakenly think that if they have high blood pressure or hypertension, that they can't take menopausal hormone therapy. And so many women who are entering menopause have hypertension. Dr. Simon, how do you explain this to them?
Well, Dr. Moore, there's a very important point to be made here. Both men and women increase their blood pressure as they age. And hypertension, the elevation of blood pressure beyond the normal range, is extremely important as a risk factor for heart attack, stroke, kidney failure, and a variety of other diseases. So a woman who has hypertension should have her blood pressure treated before she begins a course of hormone therapy. However, many women believe that if they've ever had hypertension, treated or not, that they're not candidates for hormone therapy, and nothing could be further from the truth. While women with treated hypertension are candidates for all forms of hormone therapy, there is a subtle benefit for women to use a transdermal form of estrogen. That benefit is that transdermal estrogen has a mild blood pressure lowering effect, and so, in other words, it can help along with their treatment for blood pressure to further lower their blood pressure. In some women that may have pre-hypertension, a subtle increase in their blood pressure, but not really requiring treatment, they may be able to avoid further treatment or intervention by going on a transdermal form of estrogen therapy, and because that subtle decrease in their blood pressure, get away scot-free.
Many women have heard that they can get a deep vein thrombosis, or DVT, which is a blood clot in the leg, particularly when traveling on coach class in an airplane, or if they're sedentary for a prolonged period of time, such as when recuperating from major surgery. Dr. Simon, how might this affect their choice of a menopausal hormone therapy?
Dr. Moore, this is a very important question, and one where we now have some very good information to help in selection of the most appropriate forms of estrogen therapy. We now know that as women get heavier as they age, as many women do, and as women use hormone therapy for menopausal hot flashes and night sweats, that there's a difference between oral hormone therapy and transdermal hormone therapy as it relates to their getting a blood clot or getting a subsequent blood clot if they've had one previously. We now know that there are multiple risk factors for these deep vein thromboses. You've mentioned one being sedentary after surgery, but as one gets heavier as one ages, or as one ages whether they get heavier or not, and in a subgroup of individuals who have a propensity to develop blood clots, a so-called thrombophilia, which may involve as many as 4% of all women, blood clots become a very important problem for women as they age. We now know very clearly that oral estrogen therapy significantly increases the risk of deep vein thrombosis in women as they age, or as they get heavier, or if they have that propensity to have thrombosis based on genetic factors. We also know that transdermal therapy has none of those effects. Let me give you an example. Let's imagine a woman has a prior history of a blood clot and is found by her practitioner to have a genetic predisposition to have another blood clot. We now know that women who take oral hormone therapy in that setting have a 25-fold increase in the risk of having another blood clot, whereas women who take transdermal estrogen therapy have an increase in their risk of having a blood clot no different than women not on hormone therapy, but who also have that increased genetic predisposition. So in other words, transdermal hormone therapy does not share the same risk of thrombosis as does oral hormone therapy.